morning, everybody. Welcome to our November edition of our infectious disease IIDR rounds. I'm very excited today to have with us Drs. Fiona Smaill and Amy Gillgrass, who are going to speak to us about HIV. But just to start, I thought I would put up this interesting set of figures from a new article in Nature on which diseases in the world exact the greatest toll versus which diseases get the most research funding. And I thought it was fascinating that although HIV/AIDS falls third on the greatest toll behind tuberculosis and diarrheal disease, it gets by far the lion's share of the funding. And, you know, that's a tribute to the activists who went out of their way to make sure that this disease was recognized and funded. So just some food for thought to start us off for today. So let me stop sharing so the speakers can share. But first I will introduce them. So our speakers for today are Dr. Fiona Smaill, who is a professor of pathology and molecular medicine and a medical microbiologist at the Hamilton Regional Lab Medicine Program. She's been actively involved in clinical trials in HIV management, the development of vaccines for tuberculosis, and more recently COVID-19, and the management of infections and pregnancy. Today, she'll be speaking to us about HIV, in particular, where we stand with the virus, 40 years after its first cases were reported. Our second speaker for today is Dr. Amy Gillgrass. She's an assistant professor of medicine. Her primary research focus is HIV tuberculosis co-infection. So she's batting on both sides of that disease burden fence. Using a humanized mouse model, the Gillgrass lab is currently seeking to better understand how this unique co-infection affects immune responses, treatment, prophylaxis, and disease outcomes. And today she'll be walking us through some of this work.
Okay, are you seeing a screen? Awesome. Okay, so thank you for giving me the opportunity to speak today to the IIDR. I will caveat, I don't have any introduction to HIV because I was going second, but you'll hear the intro after the fact. And I'll jump right into more the basic side of science, but how we're trying to apply it clinically as well. Okay, so first of all, you heard in that intro that I use humanized mice to try and investigate HIV as well as TB. But what is a humanized mouse? So when you hear this in the literature, you might hear many different, it applied in many different ways. Sometimes people say a mouse is humanized if you give it antibodies from a human, or if they just have one cell type from a human, etc. So in my case, we're taking human immune cells and reconstituting them in a humanized mouse model. So how exactly do we do this? So the first step is to isolate hematopoietic stem cells, and there can be multiple sources for this. In my case, I use umbilical cord blood, which is a great source of CD34 stem cells, but you can also get these from bone marrow, mobilized PBMCs, and you can do some short-term models of humanized mice with just PBMCs. So once you isolate these, then the next important component is the mouse strain. And most of the current strains are based upon these original mutations. We have an NSG model as well as an NRG model, and they have the common NOD mutation, which makes the innate immune cells such as macrophages non-functional. Then the SCID or the RAG mutation makes it so that they have no B and T cells, and the gamma chain makes it so that NK cells can't proliferate and survive. So with these strains, we irradiate them to make them even less functional and reduce numbers of non-functional immune cells from mouse. And then we can inject them. With newborn mice, we can inject them intrahepatically with these stem cells. And in the older mice, we can inject them by tail vein or IV. And then comes the waiting game, because after that, you have to wait about 12 weeks to determine whether or not the human immune cells have reconstituted the mouse. So we use flow cytometry, and you'll see some of those results coming up. So why do we want to use humanized mice? Why are they useful? Why aren't they just normal mice good enough? And what the answer here stems from the human tropism of some pathogens. So in the study of infectious disease, some pathogens are extremely hard to study or impossible to study in our normal small animal mouse models. And primary among these is HIV. HIV is human trophic. It requires human CD4 T cells, as well as co-receptors, CCR5 and CXCR4, which we do not see in normal mouse models. Other viruses or pathogens that also are human trophic are listed here. So this is not singular to HIV. They can be useful for many different pathogens. Humanized mice can also be used in allergy and autoimmunity studies, cancer studies. This is becoming more common. We just started a collaboration with the Mossman group, right? So we can use these models actually to look at human immune responses to either vaccines or cancer immunotherapies, as well as they can be useful for transplant studies as you have a foreign host and graft. Now, if you've heard about humanized mice before, you might have heard that they have developed over time. The original models were very basic. They might have just one cell type, or they had a short lifespan, etc. They have evolved, and kind of the common one I mentioned, the NRG and NSG, are quite good models, but they still have some limitations. They lack some subsets of cells, so they don't reconstitute, say, human NK cells as well. And they have low levels of myeloid cells. GVHD can develop, especially if you have any T cells that are mature T cells that are contaminating your stem cells. We see this GVHD develop later in life. Some human cytokines don't appear to be well constituted from the immune cells themselves, which can limit engraftment. And also, if we think about how T cells and B cells are trained, right? Because we're putting in stem cells, they actually have to be trained and undergo selection. And in this case, in these mice, the antigen presentation is in the context of mouse MHC, but you have a human TCR, which can be an issue. So over the past 10 years or so, there's been a lot of next generation humanized mice. And when I say humanized mice, it sounds like I'm saying one type of thing, but there's actually more than 50 models out there. And each can be specialized for the kind of question that you want to ask. So one of the well-known ones for the last while has been the BLT mice, bone marrow, liver, and thymus. So this is when you use bone marrow for the stem cells, and you implant fetal liver and thymus at the same time. This leads to increased engraftment, and the T cell education can happen in the thymus, which is beneficial for the T cell responses. But it's very challenging to do this model, as you need to get matched fetal samples. And in the US, they have run into trouble in that this type of research has been defunded, at least during the Trump era. Hopefully that changes. So another newer next generation model are ones that you actually make the mice transgenic for human cytokines. So this can promote the development of certain immune cell subsets that were low previously. So I've used the example here of the SGM3 mice. They have 3 different cytokines, which increases their myeloid cell engraftment. And we do see improved B cell responses, and we get some NK cells. What I'd like to highlight, because it's the one I'm going to use, are mice that are actually transgenic. So you can use either the NRG or the NSG base model, and then make them transgenic for human HLAs. And this can be HLA1 or 2. I use the example here of the drag mice. So they are NRGs with HLA class 2 DR4. And in the literature, it's reported that they have increased frequency of engraftment of human cells, which is ideal, right? The more human cells there, the more human-like they are. They have increased functionality or ability to respond to stimuli with cytokine production, as well as the B cells can isotype switch. They receive help from the CD4 T cells so that they can actually isotype switch and produce IgG. There's also HLA1, so a common one is A2 transgenic mice. So how these models have been really instrumental in HIV research. So while we can do non-human primate research for HIV, right, it's extremely expensive. The ethical considerations are high, and there's it's hard to get high N numbers and a lot of samples out of it. So these humanized mice models have really been used quite frequently. And the other reason is because they really recapitulate many of the clinical aspects of HIV. We can infect them vaginally, interrectally, and via IV routes. You see infection of CD4 T cells as well as depletion of CD4 T cells as they reach more chronic stages. We see macrophage infection, which is also, and dendritic cell infection, which also occurs in human infection. And you can actually treat these mice with ART and develop latency. So you can see that these mice have really enabled research on ART, antibody therapies, kind of the pathogenesis of HIV, looking at the contributions of different immune cells, latency studies. And these more recent models can be used for vaccines because they have the good T cell responses and B cell responses, as well as some cool studies looking at gene editing of immune cells with CRISPR-Cas9 pre-injection. Okay, so as I mentioned, the model that I've gone with, the next generation model that I've gone with is the humanized drag. So they have the HLA2, and I've crossed them with A2 mice, which have the human HLA1. So they're both transgenic for HLA1 and 2. And we match this to the cord blood we engraft. Okay, so here I show a graph that has the human NRG mice. Oh, sorry, I didn't do my pointer option. We have our human NRG mice, and we've engrafted them via both methods to see which one would work better, the newborn intrahepatic or the adult IV. One second, I'm just gonna close some stuff because they said my internet's not good, so I don't want it to lag for you. Okay, so you can see here that the newborn intrahepatic injections and the adult IV injections produced a good amount of human CD4 T cells. The intrahepatic was slightly higher, so this is up to 30% of the mice having human immune cells. Now, when we look at what type of immune cells are there, which is very important when we're trying to study the immune responses as well as how disease progresses, here we have a sample of a human DRAG-A2 mice. So this is mouse leukocytes. This is human leukocytes on this graph. So here are the cells we're interested in. And you can see of these cells, about 30% are the CD3 cells or T cells in general. And this can be broken down into CD8 and CD4. They actually have a little bit higher CD4, which makes them perfect for HIV infections. We also have good B cell levels. The B cell levels are high. This is an early time point at the 12 weeks. And it actually goes down and more T cells come over time. But we also see monocytes in the blood, which is an improvement again over the base model and important for HIV as macrophages are known to play a role in. Okay, so then when we look overall at immune reconstitution, so how many cells do we find in the blood that are human? In red, we see human DRAG-A2. That should be pretty consistent throughout the presentation. And then in blue, we see just our base model, NRG. And while we get good levels, like over 20% averages of human immune cells, which makes them good by all standards for experiments, have enough immune cells to be reliable, you see that in our human DRAG-A2 mice, we have very high levels. Over 50% of the immune cells are human. So the quality or the amount of engraftment is here, but we also see that I mentioned that we have to wait that 12 weeks and some reject and don't actually reconstitute. So NRGs, we have 72% engraftment success, whereas our DRAG-A2s, we have 100%. Because of that matching, it helps the cells establish. And so when we break that down by types of immune cells, we again see that the DRAG-A2s in red have much higher numbers. So this is absolute cell count per mil of plasma or of blood, sorry. It's much higher overall of the human immune cells, but you'll also see that the CD4s are higher, which is good for HIV infection. We do see higher CD19 as well, and we see higher engraftment of monocytes and macrophages. Okay, on to the HIV infections. So as I mentioned, these mice are purported to share a lot of characteristics with human disease. So I'm going to show you we've infected both DRAG-A2 and NRG mice with HIV intravaginally. Okay, and then we can assess the HIV viral load in both the plasma and the vaginal wash using RT-PCR. So what you'll see here is the viral load in both vaginal wash and plasma. Okay, so because we infected intravaginally, we see high levels at early time points that usually decrease over time at the vaginal space. In plasma, it's low to start at 2 weeks, but then increases over time and kind of plateaus, which is something you usually see clinically as well, a HIV viral set point. And lastly, when we look at the CD4 T cell frequency and compare pre-infection to a chronic kind of state at about 8 weeks, we see, especially in the DRAG-A2s, we see this drop in human CD4 T cells that we expect from a good HIV infection. So that's what's happening in the blood, but I'm very interested in what's happening at the mucosal tissues. So to confirm that we have the HIV target cells where we need them, we've done immunohistochemistry. These are vaginal cross sections. Here is the vaginal lumen, the epithelial barrier, and then the submucosal space. And the brown here is CD4 T cells. So you can see there are plenty of CD4 target cells within the vaginal space. I can tell you we've also done lungs with this, and there's lots of CD4 T cells in the lung. So it's not just that it reconstitutes in the blood, it also has spread throughout the mouse to the tissues so that they're very well reconstituted with human cells. You also see here, this is at our 8-week time point, or it might even be longer, 10-week, and we see that there's very few CD4 T cells left in the vaginal tract after that long of an infection. We also looked for macrophages in the tissues, because as I mentioned, we have monocyte reconstitution, but it's not as high as levels as we see in humans. So do we have macrophages in the tissues? And I can tell you here, we do have macrophages in the tissues, as seen by Brown, and actually these do get decreased with infection as well. In the lung, we actually see a lot more macrophages than in the vaginal tract, which makes sense. So in our I mentioned that one of the benefits of these mice can be the fact that we can get specific antibody production and isotype switching. So here we have some preliminary data that indicates that in red again, which is the DRAG-A2 mice, we get HIV specific antibodies. And this is not found in our base model. So these mice do have improved immune reconstitution. So I detailed our humanized DRAG-A2 mice, but this is not the only model that we've developed. We've also developed other models to try and solve some of the other issues that I mentioned, right? So remember how I said we have very low NK cell reconstitution. So we also have a humanized IL-15 transgenic NSG model. So it's transgenic for human IL-15, which promotes the proliferation and survival of NK cells. Okay, so in this model, if you have any kind of therapeutic that you're interested in that requires NK cells, such as an antibody that you want to direct towards something, but you require ADCC and the antibodies act through that mechanism, you need NK cells to be able to test the functionality of that. And you can see here, this human CD56 and CD3 negative are markers of human NK cells. And with our IL-15, we get up to 20% of the blood cells at later time points being NK cells. So we get really good levels of NK cells in these mice. And when you look at the numbers, over 20,000 per mil. So this can be very functional. So we wanted to use this model to look at HIV as well. So in this case, we infected the mice systemically with HIV. As I mentioned, we can use different routes. But interestingly, only 3 of the 8 mice got infected. And they were the mice with the high, well, they all had decent levels of target cells that we would usually use. It was the ones that had the highest target cells that got infected. So we're interested in pursuing this a little bit to see how the NK cells were perhaps limiting infection in this model. This brings me to HIV-TB co-infection. So why are we interested in this? You saw the slide that Lori put in at the beginning, and it really indicates that both of these are huge issues globally, right? But HIV and TB together are a huge clinical issue, and they have often been called double trouble. So I'll do a brief introduction to TB since I'm going to talk about it a bit, but it's caused by Mycobacterium tuberculosis, which is this nice rod-shaped bacteria you see here on the left. It's spread by aerosol infection, and it's extremely infectious. You only need 10 mTB to get infected, conceivably. Now, the interesting thing about TB is that there's kind of three things that can happen when exposed. You can fight it off. So there is evidence that some people get exposure and are able to get rid of the pathogen. But in most cases, people develop a latent infection where the bacteria gets walled off in the lung in a granuloma-like formation, and it prevents it from spreading and keeps it under control. But this is an indeterminate amount of time because at any time you can proceed to active infection. So there's about a 5 to 10% lifetime risk of developing active TB. Something also extremely interesting about it is the prevalence, and people are always shocked in Canada when I say this, that one quarter to 1/3 of the world's population is actually infected with MTB, and the majority of these people have latent TB, but there is 10 million people who develop active disease each year. This leads to 1.4 million deaths, and it's actually one of the top 10 causes of death worldwide, and we saw on that previous slide that it's second, really. But the really scary thing about TB is that now multi-drug resistant and extensively drug-resistant TB is presenting more frequently. So the treatment for TB is a 6-month multi-antibiotic regimen that many people fail to finish, which drives some of the development of these strains. So I think when you look at this map, you can see this is TB incidence rates, right? And as I mentioned, right, we might not talk about it too much in Canada because we have low incident rates. Although there are populations in Canada that do have high rates of TB, and that would be new immigrants to Canada that are from TB endemic areas. There's indigenous communities in Canada that have levels as high as seen in Africa, and also vulnerable populations in Canada are susceptible to TB. You can see that Africa, this dark green here, is greater than 500 per 100,000 population incidence of TB. So you can really see here in India, in parts of Asia, there's quite high levels of TB infection, and it's endemic in these areas. So the interesting part is that the high incidence of TB co-localizes with those of high HIV, right? So you can see in this graph here, this is estimated HIV prevalence in new and relapsed TB cases. So greater than 50%, sometimes greater than 60% of TB patients are also HIV co-infected in sub-Saharan Africa. So why is co-infection such an issue? So first of all, it's a huge number of people, right? 1.2 million HIV positive new TB cases globally per year. A person with HIV has 16 to 27 times more risk of developing active TB. And this is a risk of a new primary infection, a reactivation of latent TB, or reinfection. Even when on ART, this risk is increased. So TB is the most common presenting illness among people with HIV, and it's actually the leading cause of death among people with HIV. It's 390,000 people died of HIV-associated TB in 2014. And I've kind of detailed a little bit about how immune cells are important, obviously, to HIV infection, but they're also important to TB infection. So you can understand how the co-infection worsens disease outcome of both. And so why don't we know more about the HIV-TB co-infections? And part of the restraint is that, again, there's not a lot of models in which we can study this, right? And there's always limitations to human studies. The humanized mouse model that I have developed it could be a solution to studying these disease interactions more closely and the immune responses in them. So first of all, we have to make sure that the humanized mouse model works well for TB as well. Right, so here you can see we can, just like with HIV, we can infect our humanized NRG or DRAG-A2 mice with a virulent strain of TB. This is done in a level 3 facility. And here you can see an uninfected lung and an MTB infected lung from our humanized mice. And you can really see all these areas here are granulomas forming. I'm going to zoom in on the granuloma to look a little more closely on it. Here we see an H&E. This is a very nice contained kind of granuloma. You see a central necrotic core. So the granulomas actually formed in humanized mice are more human-like than those formed in other mouse models, because TB can be used in other mouse models. Here we have AFB staining, which identifies the tuberculosis bacteria. So you can see throughout, the pink staining indicates that there's quite a bit of MTB within this granuloma. But what's really cool, here I have CD4 staining, and there's a great halo of CD4 T cells surrounding this granuloma and likely trying to keep it in control. We also see macrophage marker CD68 within the granuloma, indicating the macrophages are likely the infected cells. So when we look at burden of MTB in these mice, we see that they actually get very high levels of TB in the lung, both the human NRG and the DRAG-A2. But they also show dissemination of disease, which is a hallmark of TB, human disease. So we've looked into both the spleen and the liver, and we get a dissemination at later time points. We have fluorescently tagged virulent TB, and this can let us see what immune cells are being infected. So here we've looked at our human immune cells, used markers to identify macrophage populations, and we can look in the lung at alveolar macrophages and see that about 80% of them are infected with this fluorescently tagged TB. There's also infection in the interstitial macrophages in the lung as well. So we're just starting out our co-infection. We just started mice this week. So we're very excited to progress with this part. There's kind of two major clinical scenarios we can model here. So now we know the HIV works, the TB works. So we're trying primary HIV infection and a subsequent TB infection. And clinically, this mimics a newborn born to an HIV positive mother who's subsequently exposed to TB, or an individual that has HIV and then gets a new TB infection or a re-exposure to TB. So there's kind of two ways we can do this as well. We give HIV, and I kind of mentioned that there's like an acute time point, right, where we don't see the drops in CD4s, and that would be if we infected with TB at that time, 3 weeks. Or we can wait more chronic infection where we do see impacts on CD4 T cells and then infect, right? So these would cause two different scenarios. And then we'd be assessing the HIV viral load as well as how this impacts the load of MTB in the tissues. The cool thing about this model is that, right, I mentioned we can do ART, so we can do latency studies. We can look at vaccines. So that's something I'm looking at, whether or not in HIV infected mice, we can use TB vaccines and still protect from TB. And then the second scenario would be the primary TB infection and subsequent HIV infection, right? So some argue this might be more common as TB is so endemic, they might get TB exposure before getting HIV. So we can study this as well. So in these models, basically, we can study pathogenesis of both HIV-TB and HIV-TB together, therapeutics, and vaccines. We've been looking at some therapeutics for HIV using new PrEPs, etc. As I mentioned, we're looking at TB vaccines in this context, and as well looking at kind of the immune reactions and how they affect each other. Okay, I'd like to thank both Madeline Lepard and Jackie Yang for all their hard work. They're my two master's students. So with me, we've done most of the work that we've done, and you can imagine that this is it's a hard project when it takes 6 months for you to get your mice to do your job, and you have to work in the we work in the level 3 facility, and HIV itself is level 2+. So it's a challenging project, and they've really jumped into it, and we're making a lot of progress in it, as well as my undergraduate students. And I have a lot of great collaborators, including Dr. Kaushik, Dr. Singh, Dr. Ashkar, and more recently, Dr. Mossman on the cancer project. And I really have to give special thanks to Sam and Anna, who taught us a lot in the level 3 facility. So they were essential to our work, as well as Aisha, Leila, and Cheryl for their technical help with various techniques that we've established throughout this.
So today I'm just going to summarize, if it's possible, 40 years of HIV/AIDS, and discuss just a little bit about how normal a life those living with HIV now can lead, but perhaps also raise some of the challenges. So 1981 was an important year. Charles and I got married. Reagan became president, but then survived an assassination attempt. The #1 hit was Endless Love. The space shuttle took off for the first time, and the Smurfs were on US TV. Many of you who are, of course, less younger than 40 will not recall any of these events. But what was probably more important, at least for us in the medical field, were the first reports of pneumocystis pneumonia occurring in gay men in Los Angeles. And this is 1981, when pneumocystis pneumonia, which was an infection we used to see in only significantly immune-compromised patients, often those who were on high doses of immunosuppressives. So this was a very unusual occurrence, warranting a report in MMWR. And over the following year or two, more unusual infections were occurring, predominantly in gay men, including a malignancy, Kaposi sarcoma, that had really only been seen in very elderly patients. And so this was, again, a very unusual finding. And what happened over successive years was that these types of infections and unusual cancers were also being reported in certain demographic populations, as well as those who had received blood transfusions and intravenous drug users. And it was in 1983 that the causative agent of AIDS, as it was really known then, was established. And I've put up the image here of Francois Barré-Sahosi, who was a French virologist working at the Pasteur Institute, who finally, I'm going to say, was recognized for the important work that she did with a Nobel Prize for the discovery of HIV virus, along with her colleagues. This was another infection, because I think we all recognize now that infections do jump from an animal reservoir to the human. And the understanding is, and others can speak better to this, was this developed in primates and then jumped into humans and then was transmitted widely before perhaps being recognized, and it wasn't until the cases were reported in North America that we understood the full scope of the HIV epidemic. For the next, I'm going to say 13, 14 years, this was the image of HIV. These were this is the AIDS quilt project in the Washington Mall. And every quilt represented somebody who had died of HIV. There were no treatments in those days. There was very little done in terms of prevention or education. And so this was really, to me, a very visual manifestation of what HIV did to many populations, although it was the gay men who were particularly affected. And it was they who really formed that activist movement, as Laurie mentioned at the beginning. Those of you who really don't recall these times, I would recommend that you either watch the movie or read the book, and the band played on. And for something in some ways a little bit more lighthearted, but still very poignant, It's a Sin represents the picture of London in the early 80s, when AIDS and HIV infection was decimating the population of these young people whose lives were really turned upside down by this I'm going to say epidemic. Really, the activists in HIV have had a lasting impact on how we approach, I'm going to say, community involvement, patient engagement in many diseases. And in HIV research, particularly, the community has had a very prominent role from the very early days, when, if they hadn't stepped up, the political leadership really was not responsive to any of the absolute needs. And Dr. Fauci, who was one of these early pioneers in the HIV world, recalls very clearly how the activists really were the ones who pushed them to make the discoveries that they did. However, and this is just something I want to mention as an aside, although we have made great strides in terms of recognizing what some of the risks are related to HIV, there are still many places in the world where discriminatory and punitive laws really do affect how HIV programs can be rolled out. And you can see here the green bars are those where there is no criminalization of any of these other activities, but the yellow bars are yes, and there are still very many parts of the world, and of course we know ourselves the possession of certain limited amount of drugs for personal use still is a crime in Canada. But these are the factors that I think still, when we're advocating for equality for everybody, has to be recognized. It wasn't long after the discovery of the HIV virus that we were able to recognize the life cycle of the virus in terms of binding to the CD4 cells through the CD4 receptor, the role of reverse transcription, integration, and then proteolytic cleavage. And each one of these stages enabled scientists to develop drugs that were going to be effective in managing HIV. But in the early days, we only had zidovudine, a reverse transcriptase inhibitor, developed in, I think 1987 was when that drug came available. But of course, now we know that these single drugs really were ineffective in the longer term because of the development very quickly of resistance. However, it was 1996 when finally the concept of HAART, which was highly active antiretroviral therapy, was developed. And I can remember being at the Vancouver 1996 AIDS conference, One World, One Hope. And you can see here that this is the death rate related to HIV over time. And so in 1996, with the development of these drugs and the wider rollout of treatment, the death rate from HIV dropped quite significantly. Didn't go down any further, but there was a profound impact of treatment. Now, I just wanted to take sort of an aside, because I know we've got some ID residents on the rounds, and I wanted to just discuss a little bit about how HIV can come in many ways and forms. So I just wanted to present a patient that I had been caring for many, many years, a 67-year-old European immigrant, retired welder, past medical history, mild psoriasis. He lives with his wife, one cat. He quit smoking in 1985. He drinks or admits to drinking 1 beer and 1 wine daily. And because infectious disease physicians always ask about hobbies and travel, there were none. He was hospitalized in September 2009 with a pneumonia, and his blood cultures were positive for Pasteurella maltosida. Many of you will know that this is a common organism in the normal flora of cats and dogs, and we normally think about it in the setting of an infection following an animal bite. The CT scan that was done showed the consolidation consistent with the pneumonia, but also did comment on several large lymph nodes located in the mediastinum. And the blood count did show a relative leukopenia with a white cell count of 3.7, and the lymphocyte count was below what we would call the lower limit of normal, and the platelet count was also low. I cannot recall this being a blood culture isolate. It is a very unusual organism for us to see in blood cultures. 2 years later, he recovered from his pneumonia. He was admitted with progressive decline over 6 months, worsening cough, shortness of breath, fevers and chills. The chest x-ray showed opacities, desaturated and sent to ICU. And there was a long differential, as there would be in a patient like this. And he was on ceftriaxone and azithromycin. And then because he wasn't responding, antibiotics were changed. And because, of course, I'm presenting this in the setting of HIV, he had a bronchoscopy done, which confirmed pneumocystis jirovecii pneumonia. I have to say, pneumocystis has undergone a name change. It was pneumocystis carinii. We now call it PJP. His antibody was positive for HIV. He had a very high viral load of over 600,000 copies, and his CD4 count, which is a measure of his immune system, was very low. He started treatment with what was a standard regimen there of ritonavir boosted darunavir. His comorbidities were diabetes and vascular risks. He was switched to another combination, single tablet with Triumec. And most recently, his CD4 count is 370. His viral load has been undetectable. And in fact, we've now switched him to an even simplified regimen, and he remains good. So this is just reminding you of the trajectory of HIV in the absence of treatment, a long period of asymptomatic infection lasting 10, 12 years as the CD4 count drops below 200, where the opportunistic infections will occur. So this gentleman really probably presented at the very tail end of this, and although in older people, HIV may progress a little bit more quickly, there still probably were opportunities. And my take-home message for this is, if you see a very unusual bacteremia in a patient, consider when there is underlying immune deficiency, and we may have been able to avoid that in this situation. So I just want to now go back to where we are with antiretroviral treatment in 2021. And this is the current recommendations from the International Antiviral Society, the IAS panel. And what is really, I think, quite startling about this is that we really just have two or three options that are recommended for most people. And they all have as a background the integrase inhibitors, with Bictegravir and Dolutegravir being the ones recommended. So we have Biktarvy, the single tablet regimen containing Bictegravir. We have down here Dolutegravir and lamivudine, and you'll be noticing that this actually is just 2 drugs. So the era of having to have 3 drugs in a regimen, I think, has passed. And in certain situations, the caveats here would be that if the viral load is very high, it probably wouldn't be the most appropriate regimen. This is a good option. And then there are some different combinations here using a different backbone that don't fit into the single tablet regimen, but are still very appropriate. I just wanted to go through a few points for discussion to update the group on some of the new points, new factors related to antiretroviral treatment. And I'll go through these fairly briefly because there's a lot of material to cover. So the first one that I wanted to talk about was weight gain, especially in Black women, is associated with the integrase inhibitor and tenofovir. I've been quite careful to say associated rather than a causation having been established. There was a very large study done in South Africa, published in 2019, where women and men with HIV naive to treatment were started on one of 3 different regimens. The standard was an efavirenz-based one. Then they received Dolutegravir with tenofovir or Dolutegravir with TAF. And so the startling data that came out of this was the weight gain that was seen, particularly in women, this is women and this is men, on the TAF-based regimen. And so this has led to a lot of questions about what is the nature and cause of this weight gain. At this point, they're unclear. It really is unclear what factors are contributing to this. Is it a population related to the Black women in South Africa? Does this reflect on some of the decisions we could be making here, where, of course, weight gain is seen as socially unacceptable, and, of course, can also be associated with other metabolic changes. So that is just one point that you should be aware of, that there are questions related to weight gain, particularly with the Dolutegravir-based regimen. And it does look as though TAF, which is one formulation of tenofovir, is more prone to do this than the older form of tenofovir, the TDF, tenofovir disproxyl fumarate, that we had used in the past. So just keep an eye on how this literature moves. The second one that I wanted to just comment on is that Dolutegravir is, and I've got here, no longer not recommended for women of childbearing age. So double negatives sort of make a positive, although it's not quite advocated or recommended at this point in time. So in this setting here, we've got a concern about neural tube defects, such as spina bifida, that were occurring in women from a surveillance study in Botswana. And initially there was a signal that those women who were on Dolutegravir had a higher rate of neural tube defects, leading to, in fact, recommendations that Dolutegravir should not be given to women of childbearing potential. However, as time has gone on, this association appears to be lessened, and the most recent data shows only a very tiny increase in the risk of a neural tube defect. And so as a result, the World Health Organization has sort of removed that restriction and recommended that women receive a Dolutegravir-based regimen, and the concern about pregnancy should not affect that decision. Now, the other new sort of piece of information is injectable antiretrovirals. So many patients have wanted to have different options rather than taking treatment every day, even though it is now just one pill once a day. And so there is a new agent, a long-acting injectable antiretroviral, Carbonuva, marketed here in Canada as Carbonuva, containing an integrase inhibitor as well as an NNRTI rilpivirine. And in studies that have been done, it really has been shown that the outcomes are non-inferior as compared to a standard Dolutegravir or Bacavir lamivudine regimen. And more recently, data has shown that this can be administered as infrequently as every 2 months, as compared to the original study, which was for 4 weeks. So I think we're now at the point where an injection every 2 months is a very viable option for managing HIV infection. PrEP is here to stay. So PrEP is pre-exposure prophylaxis. And with medications such as Truvada and even Carbonuva, these are very effective in people who are at risk of HIV infection to prevent the acquisition of HIV infection, taken either every day or when the risk is increased. I just want to point out one thing, however, is that this is the PrEP coverage among adults in the US, and you can see that the majority of PrEP prescriptions are for white men. If you look up here, however, at the HIV incidence, the incidence in white men is the lowest as compared to the Black African American. And so again, we have a disconnect around availability and where the absolute need is. I just wanted to remind everybody that we're now at a stage where U equals U. And so this is where if an individual is undetectable, HIV is untransmittable. And this has, I think, become a very important part of lifestyle choices for many people who have HIV infection. And counseling around this is another important component of looking after people with HIV. And the last one, and I won't go into this in any detail, is that most of what we start to see now, particularly in patients who are treated, is chronic inflammation as a clinical manifestation of HIV pathogenesis. And this is just to remind the group that the tissue damage and organ dysfunction that we see, including cardiovascular disease, kidney dysfunction, bone defects, often all relate to the immune activation that occurs in the setting of HIV. And the most important thing to manage this is to actually identify people with HIV and treat them early. It does appear that with current options for treatment, life expectancy is normal, but there are some big buts. And the big but that I've got here is that if the diagnosis is at a very low CD4 count, the improvement in life expectancy is much lower. So trying to diagnose people early before they get damage to the immune system is probably the most important thing that we can do, although preventing is even more important. Canada hasn't done too badly, but over the last 10 years, the rates of new HIV infection have remained pretty similar. And it's in areas like Saskatoon where the rates of HIV, particularly in the Indigenous population, are the highest. The goal of the world and UNAIDS was instrumental in establishing what we call 90-90-90, which is 90% of HIV people diagnosed, 90% on treatment, and 90% fully suppressed. And you can see here, these are Canadian data from, I think, 2019. We're getting close to picking up most cases. However, we're not quite at the 90 level here, except for those who are on treatment, where we are successful. So those engaged in care are able to achieve a undetectable viral load. Unfortunately, we're probably not going to meet the targets. And this is just an estimate of where that 2020 target was and where the curve is going. But what has been quite disturbing is that with COVID, the number, and this is from South Africa, the number of new infections diagnosed and new people started on treatment. And as soon as you get here, these are when the lockdowns occurred. And you can see that we've really gone back. I'm not going to say, a decade, but the discussion relates to the fact that COVID has had profound impacts on both HIV and TB in the world. You've seen this graph before, this map, with most cases of HIV occurring in Southern Africa. Keep an eye on that area there, and just look here at the percentage of the population who's received a COVID dose. And so again, here we have the continent of Africa being really left out of the healthcare that they need and deserve. And so I just wanted to finish now. I've been doing HIV work now for 40 years, and I'm just winding down my clinic. There's been an awful lot that we have achieved in this area. I'm going to say we, the world has achieved in this area, but we still have a lot of challenges. We have no vaccine, we have no cure, and we have these health inequalities. So the work is not done, and I'm passing it on to the next generation. Thank you.
Thank you both for those great talks. And yes, COVID has really made an impact not only itself, but on all these other diseases. It's quite amazing. If anyone has a question, please feel free to type it in the Q&A. We have about a minute left. In the meantime, I want to ask Amy a question. You mentioned in your Humanized Mice that you can recapitulate a lot of the cell types, but that some of the cytokine profiles were not captured. So can you comment on what those are and how it would impact the progress of the infections that you're studying?
Yeah. So it is a hard area, which is why, we are starting to do the transgenic mice and those we're identifying which ones don't get, right? So the human immune cells themselves do produce cytokines that kind of support their own growth, right? So we're okay in terms of like IL-2 and like the things that the T cells can produce, things B cell can reproduce. But some of the cytokines made by, say, epithelial cells that are mouse related would not, don't necessarily cross-react. So it is hard. I will say this, there is no perfect humanized mouse model. And each one kind of addresses something to make it better. But again, it's what question you want to ask. So, if you are particularly interested in this cell type, then you really have to think about what cytokines need to support that cell type. And then, we go from there to make the best model that will do that for you.
Well, I have a lot of admiration for you tackling such a very challenging, you and your students tackling such a very challenging model. I'm not seeing any other questions, so just in the interest of time, I will thank you both for your wonderful presentations and thank our audience for joining us today. And we will see you in December.